I see where I'm just like, you want to talk to Chad?
It's gonna pull it that way. I just click something.
Rotate around.
What? No matter what, it's gonna do that probably.
Oh, that's tricky. I haven't used it.
I put the cranberry sauce on chili.
Here we are.
I made sourdough bread for the first time last week. Oh, it's so good.
You did? Do you have a starter?
I do. Would you like some starter?
Yeah, because I'm spending $7 a loaf on sourdough bread.
Yeah. I'll do some starter and then sourdough bread and my butter. Oh, yeah. Oh my gosh, it's so good. See, she is fascinating to me. I would love to put my oven into her. But I'm really getting into the yolk. Yeah, we should all have a mushroom honey party with.
There's also a Arizona mushroom scene doing
Yes.
lecture on the 28th.
Oh, I don't know, but I used to belong.
Oh, you know.
Yeah, so they do field trips and they do dinners and they do lots of things.
Oh, that.
It's Arizona mushroom. Whatever it is. California, I used to go looking for tannics with my dad.
Gonna ask the same thing.
Yeah.
That's right, it's on you, so that's good.
And,
You
like a buyer coming down.
Pretty much.
Little buttons, $40 a pound. People making some money off mushrooms.
I've heard of the lobster mushrooms that you can pick up there. They taste like lobster. Like you can make lobster nuggets, cheese and. Yeah,
Really? So I used to think my dad was trying to lose me because we go out there and split up. Oh. When I would go to, yeah, we do have an I can't actually. Right. But in Flagstaff, when we go to farmers market, there's more there than just forages and cells when he gathers. And that's where I got the lobster.
I think that would be neat.
Mhm.
They're so helpful for. I was drinking mushroom coffee for a little while.
I've been looking for anything to get like the chocolate dish for one. We should have made the drinks of that. Somebody would show it.
Right.
There are some good ones.
Sorry.
Like, this is part of the ask them to like.
Oh. Isn't it?
If this is what I want to do about it.
I liked it too. I had to believe something. And it was actually blue.
Oh, I think now it's,
No, I think you're right, because it was caffeine free. Because it was late in the afternoon.
yes. Maybe it's not like on the beach.
So too. I think that is what it was. And there's some kind of a blue herb in there, but it turned to be blue. And it was kind of like creamy, like a latte. But it was tea.
You know, I was surprised that the coffee and cheese were so good.
Me too.
I'm not sure. I haven't been in that. Oh, really?
I haven't either, but I've heard good things. Well, I've been through a Starbucks in there.
Anyone likes it. I'm really glad I got a place. It's nice to- It was like a hurricane. Oh. My niece lives in Arkansas. Well, I stayed for a night at the hotel there, I guess. There's no hotel there. I didn't think it was. I just felt like. But now, it's not right. There's a really different house. But but anyway, here's an average. Fires, jet floods. I could call it. Yeah, but yeah, it was like.
When I looked around, and I started what I rather like writing up. It's much rock. 93 and flood where the where it's flat. Yeah. I can still remember. Thanks following like and walking and like. This really heavy shock on the wall. We used to go with the
I'm just recording right now.
I know. The only time an earthquake bothered me was. That's ready to small. Well, yeah, that's the only time that I was like, you need to worry about this. It happened to her in Jamaica. The earthquake, and you're like, but no, I don't. Me either. When I lived in Hawaii, I was laying on the beach watching, we're doing my homework. And all of a sudden, we were laying on the beach. The little distance from our height. And all of a sudden, we were like 2 feet deep in the water.
Oh my.
I'm like, well, our homework's floating around. Like, there's no nowhere, there was this big wave. Oh, geez. And I went down and then another one came and then nothing, but I was like, how weird. It always surprises me when people say, when I lived in Hawaii, and how they live. I'm like, you know what? Yeah. Why are you still in Hawaii? I know. So true. Like we have a family that just moved from Maui and we're like, and what?
Maybe they don't like to be in my Ireland, what do they call it? Ireland.
Fever.
Yeah. Something like that.
I got it for a little bit. And then I was like, well, I'm a big rock in the middle of the South Pacific. Could be worse. Yeah.
And
I got over it really quick.
moving to the beach, cause, when I moved to Kingston, on the way to spring first, did not know that, but I moved to Kingston.
Oh, gosh.
And on the way to beach. That week we were in the Dominican, I don't think the Fluminos or seas once.
Oh,
You know how much it seems.
I do. It scared me. Like,
That was Brittany. That was Brittany.
Oh, that was for you and me.
That was Brittany. She's a left startled baby.
My opposite. I don't know. I was really joking.
There he is. So you know what? This one holds your seed in, and I just saw studies that can kill you. You can explode your head.
You can explode your head.
Hi, Dr. Zelk.
Hello.
Good evening, everybody. How we doing?
Good. We're gonna turn up the volume.
Okay. I'm a little
First, I wanna
quiet.
make him co-host.
Oh, Sarah's gonna make you a co-host.
Me and Sarah played with it. Share.
It was so easy when we did it. Oh. There we go. Yes.
You want to pop open the wine yet, or?
Yeah. I think you got- Okay, there we go. Okay. We good?
Yeah, can you hear us?
Yeah, I can hear you guys. Can you hear me okay?
Oh.
Is the TV not? Let me, hold on. have everything up.
Yeah, I can hear you guys pretty well there.
I just need to figure out how to get your volume up.
Ah,
Maybe someone was.
Right?
Yeah.
Okay. I don't see a volume option on here, right?
And it was.
What about your computer stuff?
All right, Dr. Zelk, talk to us again.
all right. Can you hear me okay, or am I still pretty quiet?
You're still pretty
Well,
quiet.
because it's coming out of my computer. I don't know why it's not coming out of the TV. Well, we can put him closer.
We can make it more intimate, and I can make sure my volume's up as high as possible. And is that any better at all, or should I?
No, it's not better.
Yeah, we have you plugged into a TV, and so I thought that because when we do this for work, the sound always comes out of the TV. So I don't know. Don't know.
You're just in pair, or?
Deanna, any ideas?
Hi,
you guys.
You dropped yourself.
Volume's up all the way on the TV?
The volume, yeah, but it's coming out of my computer.
Yeah. Now it's pretty good on my side.
It's pretty good on your side.
See, now I hear him over there. It seems like to me.
I hear him right here.
I thought I could hear it over there.
And is the
Oh,
volume
what's
up on
up?
the computer?
Okay,
Professional and audio settings?
it is warm in here.
Yeah. But it's
Let me know if I need to try to do some tests or
Hi.
something.
Is the volume up all the way here? Because I hear
Yeah.
him over here.
like it's a.
How are we doing? Can you hear me now?
Nope,
He's right there, yeah.
Yeah,
Still pretty quiet?
yeah.
Yeah, but I think it's our fault. Hmm.
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 Technical things.
Yes, technical.
Oh, you're right, what's under one?
Oh.
Glory.
None of us is you, right?
About this, because it says V505,
Right, might as
V
well.
for Vizio maybe?
Izio.
Party down. We might have opened the bottle of wine a little early.
Where are you, Dr. Dave? There you are.
You can hear me now then? Good to
Oh,
see you
yeah.
guys.
Oh, I can definitely hear you.
Yeah, I was gonna start like really projecting, but that would have been really strained and aggressive. I like to speak more professionally. Well, great. So let me see what I can do on my side. I want to do a screen share. I try to include a couple of videos in the presentation. Before we start the presentation, sometimes seeing something that we're describing much more impactful than me going through a paragraph about it, right? So I'm going to see if I can share my screen here for a moment. And there we go. I think that's the right one. So now I'm going to start off with an endoscopic view of what the throat looks like for just a loud snore. This is not even upper airways resistance where the airways are really narrow like a straw, or sleep apnea where it sucks closed and stays closed. And before I do that, let me just tell everyone thank you for inviting me over into your humble abode there in Payson, Arizona. Glad to be available. And I want to use this as a way to say, yes, I'm available as we're progressing through a collaborative effort to get more capture of this hugely undiagnosed problem of sleep breathing disorders. So once I show you a couple of these videos, I'll go through my presentation, but I want you guys to feel free to ask questions. If there's something burning that you wanted to ask this whole time when you came, let's make sure the questions are asked while we're going through this. How much time do we have for the presentation?
We have about a half hour, but really like, you could go however long you want.
Okay, great, great. So you guys let me know if you guys start nodding to sleep. I'll know when that's my cue. So let me just show you what snoring looks like and how the airway narrows on itself, even before it's pathologic. So hopefully you can see this video coming up here. Can you see that okay?
No, not yet. It looks like you selected it, but it's not doing anything.
Okay, so it's playing on my side. So not visible there, huh? Okay. So let's try, well, we may not be able to do videos, and because that was playing, and I had it on the view share for the folder, and I want to make sure I can pull this up here, each individual one here. Yeah, let me try another video just to see if that's showing. Anyone see that at all?
No.
Does he have two screens?
Okay.
Deanna was asking if you have two screens.
Not set up for this talk, but what I will do is I'm going to post this presentation on a Google Drive, and by the time we're done, and I'll just get off a screen share here, stop that. So by the time we're done, later on, you can actually go to and skip to those slides that actually show a male adult version, the classic sort of sleep apnea patient that we're thinking about. You can actually watch what the process looks like, right? And then, of course, in children, it's not the same thing as an adult. It's not quite as obvious and evident. So watching them having their breathing restriction is also important to get some insight. And then finally, there's an endoscopic evaluation. We can see the back throat and where it starts to collapse behind the soft palate. And it's not just, you know, two-dimensional. The whole tubing kind of pinches in like a pinched hose. So we'll have that available maybe to share once we're done with all this. So let's see. Let me go to the presentation here and see if we can start that off here. I'm going to pull up the presentation here. I'm going to go to, I think it's the Google Chrome, share that. And then I'm going to go to the presentation here. And then I'm going to start the slideshow. Can we all see that now?
Yes.
Okay, okay. So it'd be helpful if I get started on the right slide, of course.
Oh, look, he has it right there. The Inspire.
Oh,
I just saw
Yes.
3 commercials for that Inspire thing.
Oh, they are marketing that big time. That's a big money maker. And we'll talk more about that because you're gonna have a lot of questions. And luckily, most of us in sleep disorders actually get people thinking about that. And then we describe to them the process and how much down the road it is. We can start doing some more non-invasive, less risky stuff first. So just to introduce myself, I'm a sleep specialist. I'm the medical director for Sleep Balance Academy and for the Airway Institute or Air Institute. And we train clinicians on the basics of sleep apnea management. And we want to increase the overall awareness as non-sleep specialty providers about how this impacts our general health of our patients and how we can become more active participants to learn through their own pace modules, whether you're family practice, dentists who are interested in getting into sleep apnea and understanding that. And then finally, there's a sleep consultation opportunity that's a telemedicine. So as we get into more rural areas, it's very challenging to get into your sleep groups, even in primary urban areas. It could be weeks or months now. Now it can be much faster and more convenient. You don't have to make long drives. And now we are also available to do kind of like corridor office consultations too on these patients when we're making these recommendations. So that's one service. There's also one that Dr. Wade has been signed up for too that's got some real promise called Rest Assured. And these are both consultation services that she's plugged into already. So if you want to get into some of the sleep and primary care, great. But just know that the work that Dr. Wade is doing is positioning her to be a dental sleep medicine, essentially specialist. And that's what she's been doing with us over the last year or longer now, really putting a lot of time. And I have to applaud you. You are one of our A students there. You get on the curriculum and you do it. That's great. So this is something just to introduce us. And my background again is I'm really a big sleep educator. I've been doing this for a long time. Dental sleep medicine. I've been teaching dentists about sleep for over 20 years. I've been in sleep disorders for almost 25. I'm licensed in Oregon, Washington, Colorado, possibly Arizona here soon. But our service is licensed in all 50 states. So whoever wants to have access to us can. And what we want to be aware of is just there's more to treatment than just CPAP. CPAP is fantastic, but we have to introduce all of our options to our patients. So our objectives for today is just to talk about having access to telemedicine sleep consult services, introduce you to why. Why is Dr. Wade getting into this? Why is she doing sleep apnea? She's a dentist. Well, there's a big push in the ADA and those dentists who really want to give overall global health to their patients, not just fantastic dentistry, are connecting the dots here. And then what's the role of the dental sleep medicine provider in your area now that she is getting that expertise and support from folks like us? Finally, there's some novel home sleep testing devices that you may or may not be familiar with that we're now having access to that makes life easier for patients to be evaluated. And then, of course, the novel treatments for sleep apnea. So that just gives you a heads up. We're trying to meet the ADA criteria for licensing. Most states are adopting a minimum education for dentists to actually participate in sleep apnea collaborations, is you need to meet at least 25 CE. And if you want to become board certified, which Dr. Wade's already completed the CE that would be needed. And as we're going through these processes through mentoring and treating a number of cases, she's very soon going to be board eligible if she chooses to do so. And this is some of the other aspects that we also train. A lot of chiropractors are the medical examiners nationally for Department of Transportation. So they need to be understanding of the impacts of sleep apnea on their sign-offs for their patients. And that's what the diploma looks like. Another reason why chiropractors are thinking about this is there's this really wild ocean of movement and poor posture. And if you with all these peripherals and kids have got their heads slouched down, all of us are looking down at our phones, and it really starts to make us have really poor posture. And over time, it's going to cause a lot of things to kind of collapse in on themselves, including the airway. So obviously the left side is a nice upright posture. We don't see that very often anymore. And then the right's starting to become more of the commonplace. And on top of that, believe it or not, if you have non-airway focused orthodontics, it actually tips your head inward. So traditional, what we call retractive orthodontics, can actually negatively impact your posture. It pushes pressure on the head and makes you want to lean your head in and actually have more pressure forward. And remember, every inch forward is 20 pounds more weight on your cervical spine. So we don't want forward head posture because that leads to cervicogenic headaches and TMD and all those other factors. Can you guys still hear me okay?
Yeah.
Great. So this is a link on Sleep Balance Academy where for a nominal price, whether they've got insurance or not, this is kind of like your fee-for-service discounted services. Typically, most sleep clinics will charge you probably $400 to $600 for this equivalent stuff. But basically, we consult the patient remotely, talk to them about their options, evaluate them because you're telling us that there's a high risk for sleep apnea. And then, of course, that includes interpretation and recommendations. So then the local provider can write a prescription as we're becoming more of an active partner in this process, or we can manage that as well. Let's go into some of the statistics here. So this comes from the journal Neurology, and this was actually a pretty recent article, 2017. And we used to think that the old statistics said only 5 to 9% of people had sleep apnea. Well, that was very, very low estimation, and it was false. So in the standard 30 to 60-year-old population, it's 34% of men and 17% of women. That's a large group of people. Now remember, if you're including mild sleep apnea, that's 90% undiagnosed. If you're just looking at moderate to severe sleep apnea, that's 85% undiagnosed. And it can affect a lot of things. It disrupts your sleep patterns. And I'll kind of go through why sleep apnea is so important. Before we go there, though, I want to also introduce you to a new mandate by the American Dental Association. So all boards follow what the ADA wants them to do as far as a standard of care. So this talks about the policy statement regarding sleep-related breathing disorders. And that includes loud snoring, upper airways resistance, mild, moderate, and severe sleep apnea. And you can see on point number 1, it says dentists should screen patients for OSA as part of a comprehensive medical and dental history to recognize symptoms such as sleepiness, choking, snoring, or witness apneas, and then refer these patients as needed to the appropriate physicians for proper diagnosis. Now, again, if you don't have access to those clinicians and you're doing all this screening, you're going to have a kind of a backup in the pipeline. And that's why we are so active in promoting this telemedicine service, because there's a dearth of us and we need to have an easier way to get access to people versus just putting a brick and mortar spot next to you. And to do that, you need to have some basics of sleep apnea. Now, if you want to participate as a collaborating provider, then you want to go through more training so then you can become adept at providing oral appliance therapy. And in this case, the dentist is acting more of a durable medical equipment provider, someone who's got the know-how of the teeth and the jaw and knows how to apply a medical device onto the teeth. So this just gives you some backup. And then it's also asking dentists to become more familiarized with unattended cardiorespiratory type 3 and 4 portable monitors. So now Dr. Wade has access and has been trained in several different home monitoring equipment so that if I were to write a prescription referring her to dispense a sleep study, then she can do so. And then that eases access, again, avoiding having to drive several hours or waiting several weeks or months to get access to care. Furthermore, the ADA policy states encouragement of dentists to learn more about sleep apnea, when to refer to a provider, when it's a positive screen. And then one way to screen is to be aware of all the comorbid risk factors. So obviously you want to update their health history with each patient when they're coming for general dental care. You're looking for comorbid problems that can be caused by sleep apnea, like hypertension, type 2 diabetes, stroke, chronic reflux disorder, atrial fibrillation, if you've noticed any recent weight gain, if there's any high alcohol use near bedtime. And there are some screening questionnaires that are very helpful. So the Epworth Sleepiness Scale tells us how likely someone is to doze in inappropriate situations. Stop Bang is a screener that basically asks us about neck circumference, if you snore, if you have hypertension, and if your weight is elevated above BMI of 30. Berlin questionnaire is also a longer version of that. And of course, you want to look for BMI or body mass index over 30. And once you hit age of 60, the golden years, you unfortunately have more muscle tone loss and more collapsibility of the throat. So once you hit 60, the prevalence of sleep apnea doubles. So it goes to 60% of men and 35, almost 40% of women, just because you were tough enough to make it to that far. And dentistry is starting to realize that bruxism or grinding and TMJ pain, jaw pain symptoms, and that sort of headache cluster that kind of bleeds back and forth in between a dental problem and a medical problem is starting to find a very strong connection and correlation with undiagnosed sleep apnea. And I'm going to demonstrate this to you real fast. If I'm having apnea, I'm working hard to breathe past a tight airway. So I have to access all my dilator muscles and my respiratory muscles. So my shoulders are going to come up. I'm going to pull through those tight lips there. And if you want to copy me, go for it. So you kind of are first person here. And if you pull in, you'll notice your teeth are coming together and it's working harder, your diaphragm's tightening up. And if you do that repeatedly, your teeth are actually coming into contact inappropriately and starting to wear on themselves. And don't forget, in sleep, because your pain receptors are turned down, you can bite up to 5 times harder in sleep than you can right now consciously. You can break teeth. Most teeth are broken in sleep, and then when you chew on that little bagel in the morning, it kind of stuck to it, right? It didn't break it, right?
Yes.
So that's, yeah, it's really wild. It's really wild. We all are superhuman in the wrong way.
In the wrong way.
So now, is the image of me on the side it blocking anything on your end, or is it just the slides that we're seeing?
Slides
Okay,
look
great.
good.
Good. So what you're going to see here is an example of several of the newer home monitors here. And again, part of Dr. Wade's learning process is she's basically been a guinea pig and tried all these different devices out. The one on the far right, on the fingertip, is a really cool new device called the Night Owl, and that can collect up to 7 to 10 nights of consistent data. And it's Bluetooth, so it automatically goes up to our secure portal in the morning. And it's a really impressive actual sleep test. It looks at one thing called not only high resolution pulse oximetry, but it also looks at something called peripheral arterial tonometry. And that's also being used in this other study over here to the far left top called the WatchPat, where there's a sensor on the finger there. And what that means is peripheral arterial tonometry looks at the arteries squeezing down in response to adrenaline after your throat's closing. So if your arteries squeeze down like a pinched hose and your oxygen levels drop thereafter, that's been correlated with sleep apnea without having to use a nasal cannula. Now, the gold standard is something that has a nasal cannula, look at air pressure. And you'll see the one here at the bottom left is called the Aries unit, which actually is a pulse oximeter that reads oxygen through the forehead on the skin. And the one in the middle is called the Z machine. This is actually a level 2. So level 1 is an in-lab polysomnogram. It's the big, full Monty. And then the Night Owl is a level 4. So it's a much smaller version that's more specific. Gives us a set amount of data, but not all the data. Z machine's a level 2. So it's essentially most of the information we get from the in-lab, but it's at a home environment. And you can do 2, 3, and sometimes 4 nights of data in a row in case that first night's kind of squirrely and they're not familiar with it. They can have the opportunity to try a more rested night where you're familiar with the therapy. Really cool data with the Z machine here. So I want to talk to you about some of the wild things that poor sleep and sleep apnea can do to your overall daytime health. Number one, in the last 100 years, we have gone from an average of 8 3/4 of sleep down to 6 3/4 sleep. So we've literally dropped 35% in our actual sleep amount that God wanted us to have. So what that means is try to go around thirsty and drink 1/3 less than before you're feeling quenched of your thirst, or go around and eat 1/3 of the calories that you need to sustain your level of hunger. Or actually try to breathe 1/3 less breaths all the time and see if you feel like you're not short of breath. So what happens is unfortunately, this is one of those drives that we have to live. We have to drink, we have to eat, we have to breathe, and we have to absolutely sleep to function and to survive. Actually, rats, unfortunately, have been experimented on, and after 5 days of total sleep deprivation, they go from a healthy rat to losing their hair, can't maintaining weight, agitated, and then they die. So that shows you how powerful sleep deprivation is in the short term. Imagine what happens as you whittle it away over 10, 20, 30 years. So just some really neat things that we're finding in sleep research. 1 week of insufficient sleep, so essentially 6.5 hours of sleep or less, you're actually activating inflammatory genes, which control stress response, immunity, and inflammation. And now we know all about inflammation. The more inflammation you have, the less healthy you are. It also can increase your anxiety levels because what it does, it amplifies those signals for anticipatory reactions. So if you think someone's going to try to attack you, you want to attack them first, unfortunately. So we're not quite as patient in our day-to-day if we're sleep deprived. Decrease in neurotransmitters. So you can't generate neurotransmitters appropriately, and then your mood can actually change. It impairs memory and your ability to think. So if I were to have you do 4 hours of sleep, even though you had all the time in the world to study, and then had you do a test, you would only recall about 60% of the data that you got the next day. And 6 months later, if we tried to do the same test you would never pass that 60% if you just relied on that level of recall after syncing all that information in. So sleep deprivation and cramming is not going to help you in the long term. It also will disrupt your circadian rhythms, and that will deplete your immune response. If you are a night shift worker, you are at higher risk, 5 times higher risk for all-cause cancers by the World Health Organization. So it's now a known carcinogen if you are a night shift worker. So that's what we have to be aware of, because it's constantly changing our circadian rhythm, which is going to affect all of our both relaxing and rejuvenating aspects of our nervous system and our fight or flight system. Sleeping less than 6 hours a night will increase your blood pressure. So if I have someone sleeps 5.5 hours a night and their blood pressure was perfect, and then in a few days I check it again, it'll be at least 10 points higher. It'll also increase your cortisol levels in norepinephrine, and we know that that's how it works to get us to run from the bear. Is it blocks sugar absorption on non-essential organs. So your heart and your brain can have access to more blood sugar. So that's basically causing a short-term amount of insulin resistance. So if you're constantly being exposed to those insulin-resistant promoting hormones, you will develop insulin resistance, thus type 2 diabetes. And that's just off of insufficient sleep. And then you add in processed foods and other things that we're dealing with. You can talk about all the cascade. And then finally, melatonin is 1,000 times more potent as an antioxidant than vitamin C. So it's not just to help you cue your circadian rhythm, it's actually there to help heal and repair. So if you have a lot of light, LED, bright white lights at nighttime after 5:30, it's been shown to actually cause disruption of the estrogen receptors and increase the risk of breast cancer. Pretty wild how sleep is so powerful in our overall long-term goal for health. According to Science Direct here, obstructive sleep apnea affects 20% of the US adults and 90% are undiagnosed. So that's pretty wild. So another reason why we're trying to integrate and become more available to you via telemedicine is we want to make life easier and more accessible. And if it's more, and we found that if it's more convenient based and less scary and obviously more affordable, we can actually get folks to follow up on our recommendations. Interesting little factoid, normal oxygen levels are supposed to be between 98 and 94% blood oxygen saturation. If you snore for 30 seconds straight, you can oftentimes drop the oxygen levels down to 80%. Now, in the ER, that means you're intubating. You're looking to intubate somebody. You want to save them from this oxygen drop here. So it's pretty impressive how just snoring can affect our health. And here's some statistics about how it affects productivity. $149.6 billion of economic burden every year in the US. And of course, it's a big contributor to sleepy-related driving accidents or fatigue. Don't forget, Valdez, 3 Mile Island, are two of several. There was a big gas leak in Bhopal, India. Those were all related to fatigue-related accidents or miscalculations. Really, really dramatic impacts on our lives. This is a neat infographic that talks about how sleep apnea, which we're going to start talking about next, because we were just talking about sleep deprivation, right? Now we're going to talk about oxygen levels dropping, along with the chopping up factor. This is called fragmentation. So if you don't breathe and your body has to wake you up with a shot of adrenaline 20, 30, 100 times a night, that's going to essentially what we call fragment or chop up the sleep quality. And the more chopped up the sleep quality, the more sleep deprivation you have, even though you're essentially unconscious, right? So this shows the prevalence of relationships with other commonly managed medical problems. So stroke has a 90% relationship with sleep apnea, obstructive and central. Hypertension has 77%. Coronary artery disease, 25%. My personal opinion, it's probably higher. Because remember, the most common presenting symptom for an MI is not chest pain, not shortness of breath, not nausea. Ready for it? Sudden death. So you don't ever make it. You don't ever make it. You don't ever make it. So it means we need to do more for prevention. We do a lot for secondary prevention for CAD, but we're not doing a lot for those other patients that never were able to make it past their first MI. And my feeling is there's probably a lot more related to this. Congestive heart failure has 70%. General heart disease in general, like arrhythmias, has a almost 40% relationship, like atrial fibrillation. And like I said, sudden death, any cause, is 30%. And of course, it's going to affect, poor sleep's going to affect your mood, your daytime energy levels. And the more tired you are, the more unrested you are, the hungrier you actually are. You actually generate higher drive to eat to try to deliver more sugar or more energy to the brain, because the brain's thinking that it's an energy problem when it's actually a balance problem. It's a sleep deprivation problem. Two things we have to be aware of in modern medicine is we look at the right side and we go, oh yeah, that middle-aged man who's a bit overweight and is snoring and has some hypertension or prediabetes or metabolic syndrome. We see that little yellow soft tissue here. That's the adipose tissue that actually gets larger and essentially turns that airway from a nice lean filet mignon to a ribeye steak. Okay. Yummy on your plate, not in your mouth. And so that actually makes a bigger, heavier tongue that wants to crowd everything. That's one issue, but that means by that point, that apnea has gone from either a mild case to a very severe case. And before that, modern airways are actually getting smaller. So the modern airways, the dentists know, are not able to inhabit their wisdom teeth as well. Modern airways are getting a lot more malaligned teeth and narrow arch forms, and that can affect your nasal function because the floor of your nose is the roof of your mouth. The narrower that is, the more prone you are to sinus problems and nasal breathing issues. So this is what we see with general dental imaging here. And you can see on the left side, all that malocclusion, if you go down in the column there, you'll see that the crowded teeth cause more of a V-shaped arch. And in some of the newer orthodontic teaching methods that we are promoting are going to be airway centric. So we don't want to just line up the teeth. We want to develop the arch forms. You can see the picture on the right is actually the same patient, but after they've been through what we call air expansion, where we take aligners, and those aligners can now expand the arches to give the tongue space, give the patient a more normal TMJ relationship. And the same thing is true on the far right here. You can see this patient's going from a V-shaped arch gradually as you move to the right into more of a U-shaped arch, and that's a healthier arch. In dentistry, we're training dentists to start looking past the teeth alone and looking at airway dimensions. So if you look here to the top left, if you can see the back throat when someone says, ah, that's a really nice open airway, a Malampati 1. Generally, we're seeing more of a 2, 3, and a 4 nowadays. And if you see these on the 3 and 4, you can pretty much assume someone's got an airway problem, even if they're not complaining about snoring or feeling tired. And don't forget, only 30% of patients with significant sleep apnea present with excessive daytime sleepiness. 30%. The rest of us kind of feel like we're just tired. We kind of, shrug it off. It's not really their primary symptom. It can be the other cascade of symptoms: hypertension, prediabetes, frequent urination, reflux disorder. And one really interesting thing I would like to describe to folks, the way GERD and sleep apnea are connected is not only are you making more acid production because you have stress hormones going on through your body, but more importantly, when your throat collapses, your diaphragm's pushing against your stomach, essentially trying to open up that glottis. And as it's pushing against the stomach, it pushes acid past that small cardiac sphincter at the top of the stomach, bathing the esophagus with acid, irritating it, kind of like an irritated skin. And then during the day, as you're eating stuff, you feel the irritation and you blame it on spicy foods, fatty foods, and whatnot. But there's also contribution to chemical irritation to the esophagus as well. We're also looking for tonsils to make sure they're not enlarged. And of course, look at the far right side here. Look how narrow that arch form is. That patient can't even fit one finger into the roof of their mouth. You should be able to fit 3 fingers into a normally developed arch form. 3 fingers. And that is a V shape. That, if you see that in a child, you know that you need to start working on developing that facial type. And then more small jaws, forward head postures are going to be the anatomical reasons. This is a really, really cool slide set here from William Heng. He's one of the leading orthodontists on what we call interceptive orthodontics, where we're trying to develop the arch form, not just straighten the teeth and make him look straight. So this is a patient on the far left with already a small airway before orthodontics. Then when the orthodontics pulls the face down and inward, even though the teeth look straight, you can see that the jaws pull back even further, and those arrows are even closer on that left side than they were on the far left side. The far left is before, and the second to far left is after. That's not a good airway. It may be mimicking symmetry, but it is not symmetrical. Now, if we go to the next second to the right, that's the patient prior to orthodontics. And if you start to develop the arch form, after that, if you do it appropriately, not only will the teeth be straight, but the structure of the airway will be healthier. And now you see massively improved airway dimensions. And so now this child will be healthier in the end versus the retractive. And unfortunately, retractive orthodontics didn't take into account airway development. It was just, we have small jaws, big teeth, let's correct the relationship. And it's actually not the case. We have small jaws, normal teeth, and we don't have enough room for them to be straight. That's how we have to think about airway development here. Let's see if this video shows. Nope, it hasn't buffered yet, but this is a child who's having some sleep apnea, which we'll show later on when this is updated. This is a male. Let's see if this is buffered yet. Nope, not buffered yet. So we'll be able to see that later on. And then this is the simple snoring. Let's see if we have this one. We may have to just wait. Nope, it's got an error too. Okay, well, internet. Okay, so we talked about the issues there. There's also a really cool thing that your dental sleep medicine provider can do for you too, is they can include both positional therapy and less invasive therapies to keep the airway open. Don't forget, CPAP is a balloon machine. It's not a miracle machine. It's just blowing open the airway so it doesn't collapse on itself. I call it like, it's like the rescue breather for CPR, right? It's the A part, you want to do the breathing part. Well, the A part's actually airway first. So what you want to do is either tilt the head backward to open the airway or do a jaw thrust. And that's what led 20 years ago or more for dentists to develop these newer devices called mandibular advancement devices, or MADs. And so these have been very, very well tested. They're extremely effective if in the right hands. And if you do it gradually and slowly in the right patients, you have very low side effects. And they have a very high level of compliance. 85% of patients will wear their dental appliances, and we'll talk about what the compliance is with CPAP here in a moment. So I love CPAP. Don't get me wrong, I'm a big fan of it in the right patients. If you're mild, you have a 90% chance of failing CPAP. So in the mild categories, I don't think it's appropriate in most cases. That's an AHI from 5 to 15. If you're moderate, you have closer to a 70% chance of failure. And in the severe, you've got closer to a 30% chance of failure. So in the severe category, it's actually very effective if you're super tired. If you're not super tired and you just have heart disease or other problems, and you feel more unrested after using CPAP, you will not be successful. So that's why the studies show that 1/3 to more than 50% of patients either stop using their CPAP machine or never bother to fill the prescription. And this is why I think a lot of family doctors are getting frustrated, is you go through all this work of finding the problem, diagnosing it, and then the one treatment you're given had a very low chance of being successful. It's like giving everyone who manages high blood pressure. We know that if an ACE inhibitor has no side effects, it's a fantastic first step in many patients for blood pressure control. But if you're that group that has the chronic cough, the ACE-induced cough, your likelihood of that person being compliant is almost nil, right? So the same thing is the scenario with CPAP. Now, if you look over here to the far left, on the bottom, that's a combination device. That's a dental appliance with a CPAP connected to it. So what we've done is we've gotten rid of the straps. We've made the interface smaller. Because your jaw is stable, like with CPR, you need much lower pressures. And that's one of the reasons why patients don't tolerate CPAP, is the pressures can be so uncomfortable. It's like your head's out the window at 50 miles an hour. Your lips are bumping apart and you're not having fun. So we want to know that CPAP's gold standard in the right patients that can tolerate it. And as soon as they have any problems, we want to start looking at alternatives, okay? This is a really, really cool unit here that's a consumer-based product. Has anyone heard of the Apple Watch or the Garmin with the oximeter on them?
Yes.
Or what about the Oura Ring? Oura Ring's really marketing itself big time. Yeah, Oura Ring's marketing itself big time. Now, this is actually a medical grade oximeter ring that you can wear at nighttime. And it has a high resolution pulse oximeter that actually can give you sleep data and an ODI or oxygen saturation. This is actually a great screener, and patients who want to kind of kick the tires can actually obtain one of these things and actually get a general idea of whether they have a moderate to severe level of sleep apnea. Really cool, only a few $100s, not thousands of dollars like the old pulse oximeters that we had to get for the medical offices. So Circle Plus is a really, really neat tool. We also ask our dentists to use this as the dental appliance is being adjusted. With a CPAP machine, we have a compliance report, so we can kind of guess how they're doing as far as their AHI, but with a dental appliance, we don't really know. We're just going by patients' reports on how their snore is and how they feel. And as they're wearing this, I'm actually encouraging more dentists to have their patients wear these while they're going through the therapy, and we can watch the oxygen levels go up and the apnea score to go down. So we're not over adjusting the devices too far, causing soreness in the jaw. This is an example of one of the reports. It actually does a blood pressure, a single lead ECG. It actually grabs pulse oximetry and gives you an ODI or oxygen desaturation index, which is basically an apnea hypopnea index or sleep apnea score. And at the bottom, you can see a hypnogram here or a sleep graph. So a lot of data in one little ring, which is pretty cool. I wanted to also talk to you about Jaws, A Hidden Epidemic. It's a great book as you're learning more about your pediatric populations. This orthodontist actually changed her whole practice when her kids started to look a little goofy with their teeth going wild. She didn't want to go and pull a bunch of teeth, so she learned about how to do interceptive or functional orthodontia, developing airway first, and then the teeth come in more symmetrical and attractive as a side effect. And the kid's healthier, less ADD, less issues with inattention and whatnot. Looking here, if you look at this from her book here, it says that today, an estimated 50 to 70% of US children will wear braces before adulthood. That means that their jaws are too narrow for their teeth. So we're not doing enough early on to help them keep their jaws developing in appropriate developmental stages. The skulls of people scored as being in great or obvious need of orthodontic treatment was only 36% in the medieval skulls that they assessed by anthropologists. And now in modern skulls, it was 65% were in great need. Not just a little bit, oh, I just need to adjust this one tooth, but like everything looks really wild. So we're looking at almost 3/4 of the childhood population is getting smaller and smaller jaws, which is going to then impact the development of airway problems. And then if you gain 10, 20, 30 pounds, then that's going to only amplify the problem. I'll give you just a short little history for me. I was a kid in Florida, moldy house, chronic mouth breather, tonsils out when I was 3, chronic sore throats, strep, ear infections, ear tubes, really sickly kid. I'm amazed I made it here. Mouth breather, crowded teeth. And it turns out that when I was in my late 20s, I got diagnosed with sleep apnea. I've never been overweight in my life. Never really had any complaints of snoring, but I probably very likely had some level of breathing disorder that early on because my airway was so narrow, everything was rubbing together, causing inflammation. And now I have this longer facial type here. And you're going to see more and more longer facial types. That's not normal. It's typical, but not normal. So just to give you an example that we're thinking about allergies in kids, getting the nose working better. And if your nose works better, your tongue can be in the roof of your mouth. And as a child, if your tongue's in the roof of your mouth, it pushes the teeth apart as they grow their growth spurts and helps develop arch forms. So importance of breathing and keeping the mouth closed when they're sleeping. I want to show you a couple of things that we do for nasal breathing. So nasal aid is a type of nasal insert because if your face is narrow, you don't have much bone structure to support the nasal valve. So if that collapses easily, breathe right strips, mute devices, or this thing on the left called nasal aid can actually improve nasal flow without having to go through surgery. And then there's another new CPAP alternative called Bongo RX. This is a prescription device that you can see over to the right that goes inside the nose. Now it opens the nose, but does one more really cool thing. There's a valve called an EPAP valve. So as you breathe against the valve, it partially closes and it generates its own positive airway pressure without a machine. So if you have a patient who's in the mild or moderate category and they don't want to try a CPAP right off the bat, this is a really neat tool for family practices to have access to. They're only a few $100s. They're not thousands of dollars, and it's a neat new tool to try out for those folks who want to try something more nimble and more portable. Oral appliance therapies. There's lots and lots of styles out there. They're all basically retainers in the upper and lower teeth, and they need to be connected somehow. So the EMA device has these little bands that allow the jaw to move side to side. The tap device is here in the middle with this little rod in the middle. I like this pink one because I think it's kind of cute. Who likes the pink?
I have.
Yeah. Well, the pink's really there to hide all the kind of yellowing of the clear plastic over time, so it's there for a reason. But essentially, that's really cool because it allows for normal mouth movement, so you don't feel like you're getting claustrophobic, but it also allows for freedom of movement, but keeps the mouth closed. So these are very well tolerated because they're getting softer inner liners, they're more durable, they're pretty hard to see when you're sleeping. You just pop it in your mouth. No one's like pointing at your CPAP mask because it's moving around in your bed and whatnot. And now with oral appliances, the guidelines show that it's first-line therapy for mild and moderate sleep apnea, and it's second-line therapy in severe cases. So if you try CPAP out with your patient and they're not tolerating it more than 6 hours a night, every night of the week, they're getting less and less benefits from this. So that's a patient that would benefit from considering a dental appliance. And in those cases, depending on the circumstances, these patients can actually get up to 75% treatment in a severe case. So if you go from severe sleep apnea to mild, then your risks long-term are much lower than if you did nothing. Okay. These are some digital versions. These are actually 3D printed. So technology is coming a long way where we can actually 3D print devices. This is a soft palate surgery called UPPP, the uvulopalatal pharyngoplasty. I love saying it because it sounds fancy. But essentially what we're doing is we're slicing off intact muscle tissue. And you can see here, there's some scar tissue there that actually can result in a little bit of recurrence of some of the apnea, even though you got rid of some of the tissue. And if you've ever had a patient go through this, they'll tell you 9 times out of 10, they wish they never did it. The pain we're associated with cutting through intact muscle in the throat is so much higher than higher density of pain receptors in that area. Many patients explain it as a blowtorch on the throat for 2 weeks with no recovery or respite, even if they're on high dose medication. So it's very painful, and you have to really encourage patients to be aware of this if they choose to do that. There's also a risk for regurgitation up the nose when you're drinking, and definitely don't be a wind instrument player because you won't be able to maintain your wind instrument anymore without the flap.
Don't say that word.
What's that?
I just asked Dr. Wade if she could say that word.
So let's go to. Well, the smart people only remember UPPP. So these are some really cool things that just came out this last year. I was fortunate enough to be one of the early adopters, helped these guys on the left get through the FDA, and have been helping the guys on the right to develop some more protocols on how to introduce these new therapies to providers. So the one on the left is called Excite OSA, like the word exciting. And essentially what it is the TENS unit for the tongue. And it turns out that many of us, our tongue muscles are too weak, so they fall back too easily. So if you do 20 minutes of this a day for 6 weeks, it turns out that 80% of mild sleep apnea patients have a recovery in their snoring and sleep apnea score to normal. This patient doesn't have to wear anything at nighttime. And once they get to the 6 weeks, they suggest doing it twice a week to maintain the muscle tone. This is a really cool procedure. A device called the Excite OSA. The one on the right is a really neat therapy called oral negative pressure, or INAP. And what this does is it mimics what it's like to swallow. So if you swallow right now and pay attention to your tongue, you'll feel the pressure of your tongue pushing up against the roof of your mouth. That's about 250 CPAP. I'm not CPAP, but centimeters of water pressure, but negative pressure. And this guy can make up to 120 negative pressure. And you need that to pull the tongue on the roof of the mouth. And what's really neat about this guy is as long as your nose is functioning and you're breathing well through the nose, This is much better tolerated than CPAP because it's exactly what we do at nighttime or during the day thousands of times. When you swallow, that's a very normal sensation. So instead of blowing things open, you're pulling things into the mouth and not letting them fall to the back of the throat. And this is called INAP. One other really, really neat procedure that I've been trained in here up in Portland, Oregon, and I've done many, many procedures over the last few years. I've been really excited about it because it's a non-painful way to reduce the size of the back tissues without having to cut through them. So by using very specific lasers that work on the specific deeper tissues without having to burn through the superficial layers, you don't cause ablation. So we can tighten the soft palate and shrink the tongue by doing this laser over about 30 minutes. And we do this every 3 weeks until about the 3rd or 4th session. And typically in my severe cases, I can see the apnea score go down by 50%. And many of my mild cases can actually be resolved. And this is really neat because there's no downtime. I've seen no side effects. There's no problems with taste. There's no issues with having to manage pain management afterward. If you have a little scratchy throat, it just means you need to be drinking a little bit more water because we dry the tissues out a little bit. So this is a really, really cool new up and coming procedure that can be very helpful to make the tissues, basically I call them rejuvenated because we're actually tightening those tissues up. And the laser also makes the muscles contract better. And this is one of the areas that the laser will be wanted against, plus the middle of the soft palate and the tongue as well. We mentioned the Inspire. So the Inspire is essentially a pacemaker that's implanted, and then we run the lead instead of to the heart to the hypoglossal nerve. And what we're trying to do is we're looking at your breathing pattern, and just at the right time, the pacemaker will stimulate the hypoglossal nerve, causing the tongue to come forward, hopefully, out of the throat and improving the airway dimensions. There's a very specific group of patients that are appropriate for this. First of all, you have to have failed CPAP first. Excuse me. Secondly, you need to be not any heavier than 35 BMI. And you can't be very severe. It has to be below 50 AHI. And just as a quick review, I didn't talk about that very much because part of my assumption is that we know some basic about sleep apnea. But apnea is a throat closure of 10 seconds or more, and then we generate a per hour score. Less than 5 is normal per hour. 5 to 15 is mild. 15 to 30 is moderate, and above 30 is severe. So basically 30 is every 2 minutes your throat's collapsing on you. And don't forget, I almost never see 10 seconds. It's almost always 25, 30. And I've seen a minute or longer throat closures where the patient's waking up gasping at the end of it, and many times don't even remember it, which is pretty wild. So the Inspire is a very neat option for patients who failed everything, but typically need to be within a very specific pattern there. And I really encourage you guys, if there's a patient who's asking about it, you've tried some less invasive things, that's another reason why the telemedicine is available here for you. So if you have these patients you've tried all the basics with and you're kind of frustrated, you don't know where to go next, that's when you trigger our service. And whether you're primary care or dental sleep medicine, and in some areas we're training chiropractors to be more aware of the sleep intake, we can be your tertiary specialist and even review the cases with you and our recommendations. So this is what's really powerful, is you have access to folks who can handle those harder to deal with cases. And I didn't want to go crazy long, so I want to give you guys some opportunity to actually ask some questions. So let me turn the screen share off, and we'll just pop back into the view here.
Everyone.
So did anyone fall asleep or nod off while I was talking?
No.
I don't think that's very,
Yeah.
very interesting.
Sorry, I don't agree.
When I have,
Go ahead.
well, I have some samples, like I was just gonna show, because I got that watch pad, the disposable one, I didn't send it back for recycling yet. I just show it. And then the night owl, is that one the one you can use for kids or no? There's a different one, isn't there?
So with children, it's still pretty challenging because their apneas are much smaller. They're more like hypopneas. So there is a ring called sleep image ring that can be used on kids because it's a little bit easier to use. But really, the only thing that's actually FDA cleared for children is in-lab testing. But if you want to have some assessment of how they're doing, the sleep image ring is a good option. And it's I can grab a sample real fast. One second. Let me see if I find it.
Just have this running in your office so people can watch it, like when they're sitting waiting.
Okay.
Recording
So the sleep image ring. Can you see my screen at all?
Yeah.
Yes.
So this is the sleep image ring, and it goes on the finger, and they have a pediatric and an adult size. And this also has a portal that links up to us, and we can look at the data there. I think this is probably the next best thing to an in-lab test for children because it's not as scary for them, and it at least rules out the severe or moderate cases. In the milder cases, I would go based on your clinical suspicion. You know, if they have ADD, if they have crowded dentition, and this again, if they have bedwetting, a lot of bedwetting is undiagnosed sleep apnea because they get so much of adrenaline response and their sleep quality is so chopped up that they're actually having a bedwetting because of the breathing problem. And it's not all tonsils. It really isn't. It's about arch form development.
I'm glad you said that because we've known about the bedwetting. I'm over here, by the way. But I've never understood why bedwetting was a symptom of
So
that.
essentially, bedwetting is a type of parasomnia. And what happens is through these apnea events, because you're suffocating, your stress hormones go up. And so the kidneys, we know through the angiotensin renin system there, that you're actually generating more and more of a feedback loop from the kidneys saying, hey, the blood pressure keeps spiking, the heart rate keeps going up. What's going on here? So it actually starts to generate its own response in response to that sympathetic drive. And then what do the kidneys do while they're active? They also generate more urine. So then not only are they generating more urine, but they're also generating more stress hormone. And then during these apnea events, if eventually watch the child, you'll see how much work's going on. They're literally struggling to get air past. Remember the diaphragm I told you it's pushing on the stomach? It's also pushing on the abdomen, which pushes pressure on the bladder. And then you're actually basically just doing CPR on the poor bladder for these kids. You know,
So that same cycle is going on with adults too. So people that think, oh, you know, maybe like in men, it could be prostate. It might not be prostate then. It could just be the sleep apnea because of that same cycle. Is that correct?
Exactly. The first question I ask men all the time is, do you have problems with urination during the day? Do you have frequency, urgency, or problems with flow during the day? And they say, oh no, I pee just fine. And they've also said that they get up to pee 2 or 3 times a night. That's a sleep apnea until proven otherwise.
Interesting.
Because the same thing is true. And believe it or not, that was actually one of my early symptoms. I was in my late 20s, normal weight, running all over the place. I drink a little bit too much caffeine, obviously. But I was getting up 2 or 3 times a night to pee. I'm like, what's going on here? I'm about to get a prostate checked. And I got diagnosed with moderate sleep apnea. And as soon as I got it treated, I failed CPAP first, couldn't tolerate it. And then that's what led me into dental appliance therapy early on, was I didn't want to be, untreated, and I wanted to learn more about it. It was very much in its infancy. And literally it went away. And it's been away for, I'm now 50. So I'm a much better sleeper now and much happier. I had reflux too when I was in my late 20s. And I also needed a lot more sleep. I was more prone to cold sores. I have not had a cold sore in probably over a decade. Just because I'm sleeping more.
Fascinating. I have a question. I'm taking notes.
Yeah.
But so will sleep apnea make your heart rate increase when you're sleeping? So you'll wake up and your heart is racing? Is that like
Absolutely. Yeah, absolutely. So again, don't ever call it apnea again. Call it suffocating.
I'm suffocating the night time.
And this is super important snoring has become kind of like this joke about guys snoring, and really, like you saw from the statistics, a lot of women snore, especially now that airways are getting smaller. It's happening earlier. So unfortunately, if we stick to that false stereotype, we're missing all this women's health. And what's really beautiful about dental sleep medicine is you don't have to go straight to the CPAP. If you know someone who's doing less invasive therapies like Dr. Wade, you can do the easier things. Let the guy deal with the CPAP if they don't want to do the research, be smarter about it and do things that are simpler, like dental appliances or the laser or the Exceda OSA. And that's what's really neat about having our services. I don't want to just give you CPAP. I want to give you options, and based on what we find, we can talk about those. And in some cases, say, I'll give you a scenario. Say you're a severe case of sleep apnea and you couldn't tolerate a CPAP and you don't want to do surgery. I didn't go really in depth in surgery because we're kind of getting away from a lot of those surgeries until it's really bad. So, and you get a dental appliance, and Dr. Wade's done a great job. She's adjusted it just right. You're fine. You're feeling better. But when then we test you afterward with a sleep test, you're still in a moderate category. Well, we can actually combine, mix and match things, just like we do with high blood pressure management. If we want to use an ACE and then throw a beta blocker or a diuretic, we can do those from different mechanisms of action to get the overall better response with the lowest dose per classification, so less side effects, hopefully. So we can do that with, say, a tongue exerciser, right? The Exceda OSA combined with the oral appliance might get you all the way treated. And don't forget, once you start sleeping better and feeling better, your metabolism improves, your hunger levels change. And I can tell you many, many times if someone's tired and they're starting to feel better, all of a sudden, without even asking them at the 6-month check, they're down 10 pounds and they didn't do anything different.
Yeah.
Just need to sleep.
You just need to sleep. And there's really cool data there that if you sleep an extra half hour a night, you're going to burn more calories than if you worked out an extra half an hour a day.
That's crazy.
I like that. Crazy.
Yeah, yeah. So, I mean, it's really, really neat how we can start actively doing this. And then some simple ways to do this is just, there's an app out there, a free app called Snore Lab, where patients can actually record their snoring. You can send them out with the Circle Plus ring. You want to, as clinicians, and you want to start screening your patients more actively. Those Circle rings can be resent out to patients. You can, put them in ultraviolet and then give them a little wipe down with some maybe Optum hydrogen peroxide wipes, and then set them up on an app and then send them home for a week with the Circle ring and then see what their apnea score is. And then that's another easy way to start screening your patients. Remember, in dental offices, almost like the data says, 30-something% of men, 20-ish% of women between ages of 30 and 60. So that means that there's basically, a quarter of the patients walking in every day in the dental office is undiagnosed 85% of the time. And that's why the ADA really wants us to help start looking at the throat, not just the teeth. And as you saw there, we can see a lot about facial development. That's why I'm going through aligners at the age of 50. If you see this here, I've always had narrow arch form and malaligned teeth, but now that orthodontics is focusing on airway first, and because it's easy enough to do aligners, I didn't want to wear wires at my old age. So now I'm correcting my airway, and I've actually significantly reduced my apnea just by giving myself a wider arch. And it's really simple. It doesn't hurt. And obviously the side effect is you get more aligned looking teeth, right? Which is nice for people. And luckily for us, again, in the urban mecca of Payson, there's not very many dentists that have been trained in this. And luckily, out of only a handful, maybe just under 1,000 or 1,200 dentists in the country out of hundreds of thousands, Dr. Wade has access to world-renowned airway-centric orthodontists. And so they're there to help mentor her as she's implementing these protocols in her own practice too, which is really cool. Now, again, this is just an introduction video. I oftentimes can do follow-ups if people want to go directly into insomnia or restless legs or if we want to talk more involved about children, or maybe even we can do a follow-up on many cases that have been collaborated on. Maybe there's been several referrals to Dr. Wade, and after about 5 or 6 or 10 of them, we can actually do a follow-up on how they did. And we can also learn on this too, which would be really neat.
Yeah.
And then Dr. Wade would meet her mentoring criteria for board certification.
I like that. Dr. Zelk, thank you so much for sharing and everything. I had one more question. So if somebody has like their, what is the CDL, or if they're a pilot, is there a problem with them actually getting a diagnosis? Because I know one pilot doesn't want the tests to be on his records if he does that. I'm not sure how that all works. Is there?
Well, it's really challenging because I'm a general aviation pilot. I'm not a commercial pilot. So I've heard this so many times over the years. I've written off a lot of letters for FAA and DOT. Technically, legally speaking, if they have any risk factors for sleep apnea, they should look into it. A lot of pilots and DOT drivers don't, and that's going to put the community at large at risk. So I would encourage them to do a screener. If they have any risk factors, at least put that on the file. You know, if it's a middle-aged male with a neck circumference larger than 16.5 inches, 17 inches, they're over a BMI of 35. Unfortunately, they met that risk factor. They should at least be screened.
So, but if they're diagnosed, could it negatively impact their job? Like, can you get fired for that?
Well, what they do, they don't fire you, but what they do is they put you on a medical leave until you get it corrected. Either it's surgery, CPAP, or a dental appliance, and then a follow-up test, depending on the severity. So the most important thing is, remember I told you, snoring is a smoke to a fire. So if you know, and here's the thing about pilots, they don't get paid a bunch in the beginning. The longer they're a pilot, the more money they make. And then their big thing is retirement. So if you die before your retirement, you didn't really plan it out well. So I really encourage them now. And again, a lot of pilots are really worried that they're only going to do CPAP therapy, and then they're in trouble. So I'll give you an example of a pilot I've seen recently out of an office in Colorado. They had an apnea-hypopnea index of 95. They didn't feel like they were sleepy. And they said a little tired. 95, remember, 30 is severe. 60 is very severe. 95 is like off the charts, you know. And so in that case, that patient had a very restricted arch form. We did expansion. Then we did night lays. And then we also did a mandibular advancement device. And this is a normal weight patient. And they got down to, after the expansion and the night lays, they were down to moderate. And now they qualify for a dental appliance. So what we want to do is we want to take patient safety and tell the pilot, hey, I know you don't want to talk about this, blah, 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 blah. Maybe this is the thing. Go grab a circle ring on your own, wear it for a few nights, okay? If it's bad, let's get it done because it's going to save your life. If it's marginal, if it's mild, just snoring, then we can actually tackle the snoring without you having to worry about me going through an official training. But if it's moderate or severe, it's highly encouraged that we try to actively start to treat that preventatively. And then by the time it comes around to their next medical, because most pilots that are commercial pilots actually do every 6 months, unless it's a third class medical, it's every 2 years. So again, everyone's a little different, but if they have snoring and they're like, hey, doc, can we do this on the slide? There.
Come on.
I froze.
Yeah.
I always hope I always hope I freeze like this, you know?
Yeah, you did good.
Yeah.
Thank you for spending the night with us. I appreciate it so much. We would have fed you if you were here.
It was delicious.
Absolutely. You know, as long as you guys enjoy it, that's the big thing. And then make it home safe. Hopefully there's no ice and there's no snow, but Guys, please feel free to grab more questions and please let this be kind of a catalyst to want to be more active in this process, because we really need to do more as a community. And it's our fault in sleep medicine because we're so bogged down, we're so stuck in the old days. Telemedicine is really where it's going to do it for places like Basin. So thanks so much, guys.
Thank you.
That's awesome.
Appreciate
Thank
it.
you.
Have a great night. Good to meet everybody.
Bye.
Bye bye.
Bye.
It's delightful to watch.